one wants to move out of the way.
No, it's quite all right. You don't mind.
No, but that's up here.
Lights come on, maybe the streets are alive, maybe the trees are gone. I feel my heart stop beating.
Who's the band?
My favorite song, and all the kids they dance.
Who's the band?
Kids all night.
Thank you to the young people in the audience. The rest of you had no idea, had you? You'd heard the tune. What's the song? Every Teardrop is a Waterfall, is the song. It's by Coldplay, one of my favourite bands. Does that bring my age down in your eyes? Just maybe a bit. The song is Every Teardrop is a Waterfall, and that's a very evocative idea. It's an idea that's stuck with me for quite a number of years because I work in patient safety. I do research in patient safety, trying to keep patients who come into healthcare, trying to keep them safe. And that's very important for you, even if you don't work in healthcare, because that means you. Because you know what I've noticed about this audience? You're getting older. In fact, you're getting older just as I observe you. And what happens to older people is they need more healthcare. It was the length of time that Sydney talked that made you older, yes. And older people need more healthcare. That's just a condition that we move towards, which is more complex and chronic conditions. And so I'm going to talk about the healthcare system and delve into the healthcare system for examples of this phenomenon. So I work in healthcare. The immediate reaction, if you think every teardrop is a waterfall, for me, is to think of patients and relatives who are, unfortunately, the patients are harmed and the patients and the relatives have to deal with that harm. Now, I don't know if you know about healthcare, but harm runs at about 10% of acute admissions. We deliver harm to about 10% of people who come to an inpatient setting. Most of it doesn't kill you, but a fair bit does. Now, I don't know about your industry or whether you think that's a good rate, but some experts kind of believe that's a bit on the high side. So if you roll the dice next time you go into hospital, there's a 1 in 10 chance that you'll sustain some sort of harm. The immediate reaction of everybody to that problem is to say, we better find those errors, hunt them out, and fix them. Reduce harm to some acceptable level, presumably below 10%, to some level that we would feel more happy with, we'd feel more comfortable with. And we've been trying that for 25 years, and it's flatlined. It's flatlined. 25 years ago, harm was 1 in 10 patients, and today it's 1 in 10 patients. I'm going to tell you a story about that, and I'm going to tell you a story about why it's nuts, it's crazy to keep trying to find the harm and reduce that to some number. So, let's tell you that story. So this is you, and on a typical day, when you go to work by bus or train or in the car or you walk, that wonderful thing at the top of your brainstem kicks in and starts to work on what I'm going to do today. So here you are, and you start to plan ahead, thinking, what's the day going to be like? How's it going to unfold? How am I going to get things organised? I call that your fantasy work plan. It's your fantasy about how work is going to be done that day. And so you're in work as imagined mode. Lots of people have this encoded as a to-do list. But there's also a ta-da list. Do you know the difference between a to-do list and a ta-da list? A to-do list is what you do at the start of the day when you write 20 or 30 things on a list, and then at the end of the day, you tick the 3 off that you actually accomplished. You know that paradigm? A ta-da list is totally different. You write that at the end of the day, and you write what you did accomplish. It's the same 3 things. And you go, ta-da! And it's much more satisfying, because you don't have 17 things left over that you didn't accomplish. Most people have a to-do list, they write it at the start of the day, and they don't accomplish anything like what they intended. when you get to the end of the day, you always find two things. You didn't accomplish everything you imagined you would, and your day wasn't anything like how you imagined it would be. Every day usually goes pear-shaped. If the test is the things on your to-do list. So this is a distinction between work as imagined. You are imagining, you're the expert, by the way, in what your day is going to be like when you plan it in the morning. Work as imagined and work as done. And this distinction is everywhere. My own expertise is healthcare, and I'm going to use those, the healthcare system as examples, but it will apply to your area. So you're not the only one who imagines how work is done at the start of the day. There's all sorts of people who do this for a living. They are policymakers, legislators, managers, governments, boards of directors, software designers, safety regulation agencies, teachers, researchers, etc. Hands up if you're one of those. Some of you don't want to put your hand up because you think something bad is going to happen to you shortly. So are you on this list? Most of us are on this list. They're the people Sydney was talking about, by the way. If so, you're at the blunt end of the system. And the people at the sharp end are the people actually doing the work. I like to think of these people at the blunt end, by the way, as meta workers. Their work is about other people's work. People at the sharp end in the actual workplace are people in my field who are clinicians delivering care to patients. Their work is relentlessly of the moment. They do things now. They are hands-on, working with patients, delivering care to them. Their time frame is now and in minutes, maybe hours. The people at the blunt end, while they also have a busy life, their time frame is much more elongated. In fact, they don't get information about what's happening at the sharp end, sometimes for years. Sometimes they're initiating things that are going to have something happen. Their activities may not have take-up for months or even years. So what the blunt end essentially tries to do is shape, influence, nudge behavior on the front line at the sharp end. So what they do, people, you, if you're one of these people, is something that seems absolutely logical, obvious, and feasible. They design or apply policies, rules, protocols, procedures, and even laws to make things safer for patients in my world, or workers in your world. Now, this is an extract from the State Operations Manual of a state in the US about how hospitals should run. It's guidelines for hospitals. And the manual contains 1,164 regulations and guidelines spread over 457 pages. This is the land of the free. This is the land of decentralized small government. So work as imagined says essentially we're going to prescribe the way the world works and we'd like you to follow the rules. So here's another example. I don't know if you know, but when you go into hospital, if you have an operation, many people worry about the anesthetics. That's the safest bit. In fact, the anaesthetist isn't the person to put you to sleep. He's the person or she's the person to make sure you wake up. That's their job. And that's the safest bit of healthcare, one of the safest bits of healthcare. But many people are worried about what's going to happen. I have to have an anesthetic. So this is in the box. You don't have to worry about the details. This is from Carthy in 2001 in the BMJ, and there's more regulations than this now. These are all the people who've put out guidelines for anaesthetists. Now, anaesthetists are very well-trained people, and roughly they know what to do. They know to give you medication so you go to sleep, and then you have your operation, and then you wake up, and they come bring you out of it, and then they manage you in recovery. Department of Health has over 3,000 guidelines, and the National Institute of Health and Clinical Excellence has over 1,000 guidelines. And the National Health Service in the UK, one of the staunch supporters of bureaucracy, has 152 publishers of guidelines and 17 references to guidelines about how to develop guidelines. I'm feeling like I'm in a bit of a loop here. I'm in a bit of a loop. I'd like to get out of this loop. So in healthcare, those doing work as imagined have accumulated and designed, mandated, or encouraged a bewildering list of tools, techniques, and methods to reduce harm to patients with very good intentions. Root cause analysis, hand hygiene campaigns, failure modes, effect analysis. I don't really have enough slides to put all the things that people have invented through their inventiveness, through their work as imagined brain. But the rate of harm, as I said, is flatlined. Now, in 25 years, I'll be very serious about this, in 25 years, that rate has flatlined. We harmed 25 years ago 1 in 10 patients, we do now, or some of these are very minor. And that's a real troublesome thing because in healthcare we've probably spent, I don't know, trillions of dollars worldwide trying to reduce harm. Trillions. That's even bigger than your billions. I'm raising the stakes. Trillions worldwide. And we haven't reduced that. Now, I just want to put a caveat on that, just so you think I'm being melodramatic, so you don't think I'm being melodramatic. In that 25 years, we've had a medical miracle avalanche of new technology, new things we can do for people, treating people who are much more complex, keeping them alive longer, dealing with chronic and complex conditions. It's been amazing, astonishing, the medical miracles that now occur in diagnostic and treatment and other forms of technology and techniques. So we can give heart bypasses to 80-year-olds, do keyhole surgery, keep people well who have HIV, AIDS, whereas 25 years ago, we couldn't do those things. So maybe, just maybe, holding harm at 10% is a success story in healthcare. But I'd put it to you that if that's the level of harm, next time you go into hospital, you'll be a bit worried and Jeffrey's words will be just playing in your ear as you go in, okay? But the rates of harm haven't reduced far enough. I'm just going to do what you did and ignore it.
I stole it. Mutiny.
You're a leader in so many ways, Sydney. Don't you agree? But I'm sure you'd agree with me that no matter how you slice and dice that question, those rates haven't fallen far enough. Meanwhile, though, work is getting done despite all the rules and policies and procedures by clinicians who are relatively autonomous people. And they do interesting things when they do work. Now I'm entering the work as done. So they do workarounds. They don't know there's all those policies, many of them. In fact, if you talk to surgeons, they don't know anything other than there's a scalpel and an anaesthetist and a patient in front of them. So people do all sorts of workarounds in the workplace. Here's a glove over a smoke alarm because when they nebulize patients, the smoke alarm kept going off. Here's somebody using a leg strap from a patient, hope the patient didn't keep falling over, holding an IV to a pole as the holding clasp had broken. And here's people using plastic bags because there was a gumboot Wellington sort of shortage. The other thing is work is very fragmented on the front line in clinical land. So here's a study from Westbrook in 2010 about doctors in emergency departments. You've been to an emergency department, they're a bit hustle-bustle while you go in with something wrong with you and you want them to fix you. So emergency department doctors were interrupted 6.6 times per hour. They were interrupted in 11% of all their tasks. They multitasked 12% of the time. I presume that was the female emergency doctors. They spent on average 1.5 minutes on any one task. When interrupted, they spent more time on the task. Well, that's pretty logical. And here's the kicker. If they got interrupted, there was only about a 1 in 5 chance they'd return to the task they were interrupted from. Now, if you're in the emergency department receiving care and the doctor gets called away for some reason, it's a bit nerve-wracking if they never come back. So workers imagined folks often have some sort of linear, mechanistic view of the system where they say, we're going to prescribe the way work is done, but work isn't done the way they think it is, and therefore there's a gulf. And it's not linear. Instead, healthcare is, to use the jargon, a complex adaptive system delivered by people on the front line who flex and adjust to the circumstances. And in healthcare, they flex and adjust to the circumstances in orders of magnitude more than anywhere else I know. They certainly don't deliver care in the way the blunt end prescriptivists want them to. So the amazing thing about healthcare is not that we harm people in 10% of cases. And by the way, the 3 top harms in healthcare, next time you go, you can get an infection sustained by the health system. You didn't have it when you went in. You can fall while you're on some drug regime and you hurt yourself, and that shouldn't happen. Or you can get a medication error. Wrong dose of medication, wrong time it was delivered, somebody else's medication. That's always a bit worrying. So those are the top 3. And they're happening in every hospital worldwide right now on a continuous basis. They've proven to be very hard problems to solve. So there you go. I'm really scaring you now, aren't I? The amazing thing about healthcare, though, isn't that it produces adverse events in 10% of cases. That's not the astonishing thing. The astonishing thing is, in a system this complex, they manage to get 90% of care right on a continuous basis. That's the astonishing thing about healthcare. And one of the astonishing other things is we've done enormous amounts to try and reduce the 10% harm to some mythical figure, and we've been unable to do so. But we almost never look at when things go right and wonder, how does that occur in a complex adaptive system, and what can we learn from that? Now, it's my contention that maybe we'll still do safety 1 stuff when things go wrong. And we'll still have, every time there's a major stuff up, inquiries, and we'll have root cause analysis, and we'll have all the things you know about. And we call that safety 1. But what we should also be doing is thinking through and really understanding and doing micro-experiments in the world where things go right. I wonder what occurs in a complex system where there's lots and lots of people, lots of clinicians dealing with a case, how that manages to thread the needle and go right. We need to understand that if we're really going to tackle safety. And Holdnagel calls that safety too. So few people have ever looked at why things go right so often. And this isn't just healthcare, it's your business too. How on earth does that happen? That's the magic of organizations. Not that they have safety breaches and have people harmed. The absolute magic of most organizations is, how can things that are essentially pathological, because that's what most organizations are, how can they get things right so often? And surely we should understand that if we're going to be experts in safety, to keep things safe. So if I walk into a public hospital in New South Wales and chat to the frontline people, the doctors, young nurses on the in a ward, what none of them know is that there are 600 policies in operation right now meant to guide their work. And if I ask them to name 3, they'll be buggered if they can do so. Do you have that language, by the way? We have that in healthcare. Then when I observe their behaviours on the front line, I see them taking patient histories, giving out medications, doing procedures, taking x-rays, tending to patients' needs and caring for them, and it doesn't look anything like the guideline or the policy or the prescription. Instead, there's a lot of fraught, time-pressed, relentlessly busy people doing work on virtually across the entire shift. So healthcare doesn't look like the pristine, logical world dictated by the workers' imagined proponents. And it never unfolds like a policy or procedure says it should. And you know that down to your bootstraps, because yours doesn't either when you're doing your to-do list at the start of the day. It never takes place the way you plan it. So why would we think, as safety specialists, that other people's world is going to unfold the way our policies and our guidelines and our procedures tell them it should? That's not going to happen for anybody, because it doesn't happen for you every day when you go to work, on the bus, on the train, in the car, or walk. And you make your way to work and you plan your day. So healthcare doesn't look like this. It doesn't look like the organization chart with the CEO at the top and the clinicians working below and, carrying out orders or instructions. It looks like this. It's a complex adaptive system. We can't just prescribe things and expect them to be taken up on a one-to-one basis in a linear fashion. By the way, that's a systems dynamics diagram, but it's not the whole health system. That's only an emergency department. If you're going to do a systems diagram of the whole of an entire hospital, say a big teaching hospital, it's going to look far more complex, orders of magnitude again more complex than that. So why would we think that there's going to be a take-up with prescriptivist things? Therefore, the only real solution is to try and reconcile work as imagined and work as done. And as it happens, that's the next book that Bob Weers, Eric Hollnagel and I have in press. Well, it's not quite in press. I'm just putting the finishing touches to it at the moment. How do we reconcile work as imagined and work as done? Because I think that's a central core task for us. A health system where the work as imagined policies, regulations, standards, etc. are much closer to understanding how work is actually done. And that's your job as well. That's your job if you're a safety specialist, to really understand how work is done and fast feed that back into your policies, procedures, etc. And the other thing is, I'd take Sydney's point, don't have as many. It's madness to have them for how to clean up a pigeon. My own university has had the idea, anybody from Macquarie University? It's had the idea that senior people need shooter training. That is, in case a crazed gunman comes onto the university premises and starts to shoot people up. To be frank, I don't think shooter training is actually going to help. But more importantly, its remote possibility is so low that maybe we shouldn't invest in that policy. I haven't, though, been brave enough to go and knock on the Vice-Chancellor's door and tell him. So a message to blunt end people: learn how work actually works, really right down to your bootstraps. You know a lot, if you're a safety person, about how errors manifest and how to do a root cause analysis or an analysis or something of the errors. My best guess is you don't know as much about how work actually works if you're remote from the coalface. And the more remote you are from the front line, the less you'll actually understand. So it's a plea for blunt end people to learn how the world actually works. And a message to sharp end people: don't sit there smugly saying, we're doing all the work, we're pretty good. You really need to learn to work much more closely with work as imagined people, because it's a partnership. It's a partnership. My bottom line: in life, in marriage, in affairs of the heart, in friendships, in international relations, and in working environments, it's always better to engage with your partner or partners. Thank you very much indeed.